28, and in the ring binder, we're on 27. So 28 in the textbook, 27 in the ring binder. So first we'll talk about us as caregivers and in terms of our risk factors associated with taking care of clients. Yesterday we said the most common injury to the resident was what? Falls. And they would break their hip. Who knows the most common injury to healthcare providers?
Backs.
Their backs, absolutely. We don't use proper technique for lifting. We end up with lower back injuries, potentially lower back surgeries, and if you know anybody that has had back surgery or a back injury, it's a chronic event. It's going to be with them forever. It's the #1 cause of disability from work for healthcare providers. And so what we have to make sure is even though we want to turn these individuals, we want to get them up, we want to keep them mobile, we want to make sure that we are safe first. So on page 28 of your textbook, there's a yellow box, which starts off with what are things that we are going to do as the provider to make sure that we don't injure ourselves. And the first thing we're going to go in and we're going to assess the situation. If you go in the room and grandma's 90 pounds, you're probably not very concerned. If you go in the room and grandma's 500 pounds, you need to have a totally different plan for how you're going to approach any type of movement, even turning them in the bed. Then you're going to get the appropriate resources. Is that an extra person? Is that a lift? Is that considering using a draw sheet? Then when you go back in the room, you're going to move things out of the way. Make sure that the slippers aren't in the way, the night table's not in the way, so that when you get ready to do the movement, you don't end up tripping and falling yourself. You're going to make sure the client knows what the plan is. That we're going to stand on 3 or we're going to turn. Because again, if they feel like they're falling, they're likely to jump or grab something and maybe even grab you. You also want to think about your body mechanics. Everything you do should be from your legs, from your thighs. Our power is in our legs. We don't want to be bending at the waist, twisting, using any of our lower back for that mechanism. If any of you have been to a gym like Planet Fitness, and I use that as an example because that's where I go, there is a circuit room. And in this circuit room, there's 10 machines. And it gives you this plan of attack for about a 30-minute approach. And you're on a machine, and then you do some steps, and you're on a machine, and you do some steps. And you circuit around, and you can get a workout done in 30 minutes. Well, there is the psychology behind how those machines are set up, if you've never thought about it. Anybody who's been there know what the very first machine is on the left on any of the Planet Fitness?
Legs.
The legs, absolutely. It's a leg press. And you sit down and you adjust your weight, and you're taking your legs and you're pushing the leg press. Most of you, no matter what your size or experience with exercising, probably can leg press 100 pounds. Any of you in this room. I mean, I can go in there without having prepared and do 130 to 150 and do 10 reps. And I'm not a strong girl. So you feel really excited about what you just did. And then you go to the next one. It's also a leg machine. And it's now where I'm lifting and bending my knees. Again, a lot of power in that. Now my weight's down a little bit, maybe 65, 75, but you're feeling pretty strong. About the time you get to the 4th machine and you're working your upper body, I'm down to about 25 pounds and I'm dying to try to push that weight up because we don't have the power in our upper body. So we want to take advantage of that when we're moving and transferring residents. We also want to make sure that our stance is about shoulder width apart, and the closer the object is to us, the less likely we are to get injured. If we just even pick up something like a chair, if it's right next to us and we lift it, it's easy. If we reach out, our balance is off and we're going to run the risk of falling. So all of those things need to be in place when you get ready to do your transfers. Don't put yourself at risk. Now I said to you yesterday that you're not going to see a lot of teamwork. So that's what makes this hard, is because you know you need someone else and no one's responding to you. Or you choose to work in home care and you are the sole provider of making that transfer and move. You're going to, again, have to use good judgment. A lot of our larger clients, we pretty much require that they have a lift. It's like a Hoyer sling type lift to make it easier. But again, you want to be safe with you and the client when you're doing that. So that's for you. Now our first goal for the resident is I want my resident to ambulate whenever possible. You're going to want to know that word. Ambulate refers to them walking around, and them being up and about. Because if I am up and about, I improve circulation, I improve oxygenation, I feel better, I have joint mobility, I don't have as much risk for contractures, I don't have as much risk for skin breakdown, so that's the goal. But we said yesterday that not everybody is going to be safe walking around, that we're going to have some folks that might have to have a Mary walker or some sort of device to assist them. Maybe it's a walker, but many of them are only going to be able to make it from the bed to the wheelchair, or the wheelchair to the shower chair, or the shower chair back to the bed. They're not necessarily going to be able to ambulate. So because of that, since they are in the sitting or lying position more frequently than we would be, we've got to change their position. And we have to change that every 2 hours. Every 2 hours, if they are in bed, we're going to turn them. Now there's some different positions we can use, but primarily we're only going to use 2 positions for the resident. Supine, which means they're laying on their back, and lateral, which means they're laying on their side. When you guys get to clinical, there's going to be a turn schedule in their closet. And for example, let's say something like 8 a.m. on their back, 10 a.m. facing the window, 12 noon on their back, 2 p.m. facing the door, 4 p.m. on their back, 6 p.m. facing the window, and so on. And so we're going from supine, lateral, supine, lateral, supine, lateral. We don't put them on our belly, and we'll talk about that in a few minutes. And there's some other positions for procedures that we're not going to do. Our goal with doing that is to reduce the chance that they will have skin breakdown, also known as a bed sore, also known as a decubitus ulcer. Now, if you got up this morning and you had been sleeping on your hand last night, and you got up and looked in the mirror, what would you likely see? Your handprint. Because what you did is you displaced the blood flow to that part of the face temporarily. But when you remove it, you jump in the shower, you get up, you look in the mirror ready to put your makeup on, the likelihood is that that mark is gone, correct? Because you've got healthy skin where the blood flow is going to be restored to that area. In our elderly residents, they don't have that type of healthy skin. The thin skin is thinner, it's drier, it is more wrinkled, and so what ends up happening is you turn them, you see an area of redness in a part of their body, and 15-20 minutes later, it's still red. It has not restored back to the normal color. That is considered a stage 1 bed sore or stage 1 decubitus ulcer. And these are listed on the bottom of 27 for you in the ring binder. So the first thing I would want to note is if I turn my resident and I see a reddened area and I recheck it 15 or more minutes later and it is still red, that is a warning. The other thing that can take place as part of that stage 1 is it could also begin to have a blister. Much like burning your finger, you would have a little water blister there that would be intact. Okay, that would be part of stage 1, that there'd be just enough friction that occurred on the sheets and the skin that it created that blister. If that blister pops, or when it pops, they are in stage 2. Now we've removed the first layer, the outermost layer, which is called the epidermis. You don't need to know that, but just so you know that name. And now you are into the dermis, and now I have an open port for infection. I've got more tissue being rubbed away. And once I begin to rub that area of open skin, I'm going to get down into the subcutaneous tissue. And that's going to be stage 3. Now I'm really in trouble. That should not have happened. Somebody should have noted this long ago, but unfortunately it does happen. And if I still don't treat it, or I don't make sure that they stay off that area, I can get to the point that I can get all the way down to muscles, tendon, and even bone in a stage 4 decubitus. If you want to look at some graphic images, go to Google Images and put in stage 3 or stage 4 decubitus.
That's what we, like, in the ER I worked in, that's primarily what we got. It was mostly people going to visit their family members. They hadn't seen in a long time, and they realized that they'd been neglected at their nursing home, and it was, like, really bad. Like, I saw a bunch of bad stuff, and that was probably the worst thing that I saw.
Yeah, and there's like some that you could put your whole fist down in a cavity.
The saddest thing I've ever seen.
Yeah.
Like,
so when you say lateral, I think of the anatomy term lateral.
On your side.
Okay, that's what I was thinking.
Yeah, so just meaning left lateral means on your left side, right lateral means on your right, laying on your right side, supine laying on your back.
That's what I thought.
Yeah.
Yeah.
For that, so like if a person, if those are the only two positions you can get a person into, obviously you're gonna be feeding them while they're in their bed.
Correct.
Do you wanna do it while they're on their side opposed to on their back?
Well, supine refers to being on your back, but there's a term that we'll talk about in a minute, I'll go ahead and refer to it now, it's called Fowler's. And Fowler's is the degree at which you raise the head of the bed.
Okay.
They're still on their back, but I raise the head of the bed.
Okay.
So I obviously would do that if I'm gonna have to feed them in bed or provide oral care, or anything that would put them at risk for choking.
Okay.
Now, with the decubitus ulcers, again, these should not be happening, but they are. Most of these facilities have a full-time wound nurse. That just blows my mind. Why not pay for 3 additional CNAs every shift and prevent this instead of be reactive and go around staging all of these wounds? But they go through and they stage them, 1, 2, 3, or 4, and they develop a care plan in order to resolve that. Now, wound management is a multi-billion-dollar industry now. It's crazy what we've been able to come up with. Now, I'm glad, because there is a need for wound management. After surgery, infections can happen. So it's not that we don't need that. We just don't need it as aggressively as we see in long-term care. But one of the things they might do, and when they note that they have particularly a stage 3 or 4 decubitus, is they might put them on what's called a wound vac. A wound vac, and this is not in your book, but a wound vac is this adhesive disc that goes over the wound, it kind of seals it, has a hose attached to it. The hose attaches to a suction canister that you actually can clip on your belt clip, and they turn it on, and intermittently it's going to do this. It's going to pause, and then it's going to... And what it's doing literally is sucking the wound, okay? Now, the common sense is, let's suck the pus, let's suck the drainage and stuff away from the wound. The thing that we didn't think about in medicine is that blood carries oxygen. And if I suck the blood to the surface of the skin, I bring more oxygen to that tissue, I promote healing. So it's kind of the concept of your first hickey, you know, that suck the blood to the surface of the skin. That's what this wound vac is doing. And it's creating this area for oxygen to get to the skin. If that's not enough, they might put them in a hyperbaric chamber. They've got one of these at Spartanburg Regional, and they'll put you in there and seal you in, and they pump these enormous concentrations of oxygen in there. So what you're breathing is much more rich than atmospheric oxygen. And so now those little blood cells, the hemoglobin where the oxygen's piggybacked onto them that's circulating around, I mean, they're like triple piggybacked. I mean, that's bombarded the blood cells. So as the blood circulates, there's oversaturation of oxygen, and hopefully it offloads to the tissue and promotes healing. Another thing they're doing is they take your own blood. They draw your blood from you, like giving a blood donation. They spin it down and they take out the platelets and they divide it out. And they create a salve with a combination of your blood products and an antibiotic type cream or ointment. And they pack your wound with it, because you're less likely to reject a component of medication that has your cellular properties in it. So fascinating stuff going on with wound care, but I'd really like to think that we wouldn't have to do that much of it in long-term care. You guys are going to meet a client. His name is Barry. Barry was in his mid-40s. He was actually the head of dietary department for nursing homes in the upstate. And one afternoon, he had a sharp stabbing pain through to his chest, collapsed to the floor, crawled to get 911 phone. They got him to the emergency room and realized he had an aorta, which was dissecting. The aorta is the largest artery coming off your heart, going right down the center of your cavity, and his was beginning to rip and dissect. You usually die in minutes from that because you just bleed out. And so they, of course, forewarned the family, we got to get him to surgery, he's probably not going to survive, and they went in and did surgery. Well, he did survive. But a combination of the dissection process and the combination of surgery where they had to bypass the blood flow while they worked on that, the lower part of his body didn't get blood and oxygen for too long a period of time, and he came out of there paralyzed from the waist down. Okay? So he survived, but he's paralyzed from the waist down. He went through all of the process of rehab and transitional care and restorative care and used up his 100 days, and he ended up with a bed sore. And so then he got moved to long-term care side because at this point, he didn't have any resources to be able to be cared for. As they're taking care of that wound, which was on his buttocks, a sacral decubitus, nobody was paying attention to his heels. And when you're paralyzed, you don't feel what's going on there, but you still occasionally have some twitches of those extremities that still can create friction to that body part. Nobody was looking at his heels. By the time somebody noticed it, he had a stage 3 decubitus ulcer on his heel. The infection had gone to the bone. He ended up having an amputation of one of his legs, just above the knee, from a bone infection from a bed sore. Now, he has an incredible attitude about it, because he'll tell you, guys, be the eyes for me where I can't see, but just know that got rid of 10 pounds and I'll have to lug around as much. But he tries to stay so positive. But you can imagine that even a healthy individual, he has deteriorated over time. And he's now been there probably 8 years. Lost everything, was not married. His mother's elderly, can't care for him. And he'll live there until he passes. That could be years before he passes. But all of that from a bed sore. So we've got to be very proactive. So when we're turning them every 2 hours, make sure you're looking for areas that are high risk. I put a handout in your ring binder that shows some of those areas that are at high risk. But basically just think about it as being areas where there is bony prominences or bony areas of less skin. All right, let's come back to positions again for just a minute. Lateral is going to be on the side, and again, it can be left lateral or right lateral. Supine is on your back. Prone is the word for on your belly. Okay, I want you to know the word, but I want you to understand we're not going to put them on their belly. They don't have enough chest wall strength to get good, deep rest and oxygenation when they're on their belly. If they're weak or have contractures, they may not be able to move their head from side to side against the pillow. They are too much at risk to be put prone. Now, if a resident puts themselves in the prone position, the belief is they can get themselves out of it, so you don't have to go in there and say, no, you can't lay on your belly. They can lay on their belly. Another position you're going to see is called Sims. Sims is basically half lateral, half prone. So the upper part of my body is almost belly down. The lower part of the body is on the side. And this is the position typically for an enema, a suppository, doing a rectal temperature, something so that we can access the rectal area easily while still maintaining a level of comfort for them. And then the other position I referred to just a minute ago is Fowler's. Fowler's is the degree to which the head of the bed is elevated. So we can have a low Fowler's that might be 10–15% for somebody who has reflux, or somebody that's a little short of breath when they lay flat. I might have a moderate Fowler's. I might have a high Fowler's, but it's the degree at which we raise the head of the bed. And again, we're going to use that high Fowler's if we have to be feeding them in the bed, providing oral care, drinking fluids. We need to have the head of the bed elevated so we don't put them at risk for choking or aspirating. All right, so if we get them up and they're having any trouble at all with mobility, we can use something called a gait belt or transfer belt. Gait is the medical term for your balance or your stance. And so a gait belt or transfer belt is a device that allows me to have something to hold on to other than clothing, belt loops, underarms, things where I'm going to create a problem.
We use that at my facility, and that moves up the residents.
It can create bruises, absolutely, because it is a friction. It's like, it would be like having this around me, and depending on how snug it is or how it rubs on the skin, but the idea is it gives you something to hold on to, because if you're holding clothing, it can tear or rip. If you're trying to get them under their arm, we can create just as many bruises by grabbing areas of their body. And again, the skin is thin and it bruises easily in the elderly. And so we know that's going to happen. One of the key things with that is that we know that when we start looking at bruises, and we'll talk more about this in the abuse chapter, there are areas that make sense where bruises are, and there's areas that don't make sense. And so, we understand there are certain areas you're going to see bruising from our elderly residents. But with our transfer belt or gait belt, we're going to put that around the resident. We're going to put it just snug enough so that our fingers go underneath it. And this will have to be somebody who at least can stand and bear weight, that allows us to assist them to a standing position and or transfer them possibly from bed to wheelchair. You guys will actually have 2 skills today that you will be learning, in which you will be using a transfer belt. The other thing is, if you're ambulating that resident with a transfer belt and holding on to it, then if they go to fall or have their balance, I've got a hold again of something that is safe, and with upward grasp, I ought to be able to at least slow down the rate at which they're falling. If I hold like this, they can jerk that belt right underneath us. If I'm just holding them and they go to fall, I can create an injury grabbing an arm or grabbing something as they're going to fall. So the guideline with this transfer belt, or even if not, is to always be slightly behind and to one side. So as I'm walking with them, if they are unsteady and their gait is unsteady and they go to fall, my goal is to work them back towards me and ease them to the ground. Now we both are probably going to land on the ground, and it still may be a thud, but what I'm trying to do is I'm trying to slow down the rate at which they hit. You guys do not need to know this, but this is pretty fascinating, kind of helps make a point. Ooh, wow, that's an old formula from the past for some of you guys in one of your science classes. But KE is kinetic energy, M is mass, V is velocity. So what it says is the amount of kinetic energy in that motion, in this case the fall, is mass, which is your weight, divided in half, times velocity, which is the speed at which you fall, squared. So what that says is it's not how big you are, it's how fast you fall. So again, you don't have to know that formula, I'm not going to put numbers in it, but it helps you understand that my goal to getting them down to the ground was just to slow down the speed at which because if I slow the speed, I reduce the kinetic energy, and I reduce the chance that they're going to be as injured as they might be. Again, in your ring binder, I put a picture in there of just kind of showing you how to kind of widen your stance and help that individual down to the ground if that happens. Hopefully, again, it won't, but if it does, that you can ease them to the ground. Now, there are other things that we can use in transfers of a gait belt. One is called a draw sheet. Nothing fancy about a draw sheet. It's a flat sheet of a bed that's placed the opposite direction as when you make the bed. So I take the flat sheet and I fold it and I put it side to side, not head to foot. And now what I can do is I can take 2 individuals, so Nina and I can get on one side and the other, and I can grab this wad of sheet, she can grab the other side, and again, working together, we can say, let's move up on 3, and we're moving the sheet. Again, we're not grabbing clothing, we're not grabbing skin, we've just got a hold of the sheet. And when you place it on the bed, it's going to be in the area of the largest bulk of weight, which is typically from about your shoulder blades to about your mid-thigh with that sheet. Not just moving up and down the bed, but even side to side. I can reach over and grab the draw sheet and pull the draw sheet towards me and let them roll towards me. So again, it's an easier move. They also have transfer boards or smooth movers. Those are just slick boards that if I have to move from one bed to another or stretcher, I can kind of slide that in and help them ease over. And again, usually that's slid under the sheet, so their skin is still on the sheet. It's not their skin running across a board. Even though it's smooth surface, they still can have injuries and tears to the skin. There is trapeze bars that many times will help in the transfer. If they do have their ability to use their upper body, then they can assist by holding the trapeze bar. That is not commonly seen in long-term care. That's seen more often in acute care settings, primarily orthopedic settings, but just know what those are. The type of device that you will probably use more than any is going to be some type of lift. And there's 2 types of lift. One's in your book, which is a Hoyer lift or a sling lift, and one you'll use in clinical, which is a standing lift. Either way, again, your goal is to reduce injury to yourself, reduce harm to the resident, and be able to make those moves and not have them confined to one position or one location. The Hoyer or sling lift we've got in the lab and we'll show you, but basically it's like sitting in a big sling and you can just lift them, move over to another chair, toilet, whatever needs to happen, and set them back down. The standing lift has a very wide band that goes around the torso, and then the resident holds on to like bicycle handles, and it hydraulically lifts, and it puts them in a standing position, but they're not bearing weight on their legs. And so that's what's used a lot at Magnolia, and you guys will get a chance to experience those lifts. Any of these devices that are made available to you, use them to your benefit. Now, even with using them, there's also 3 other words I want you to be aware of in terms of making the decision about using them. And that is your resident capable of assisting you in any way? There is 3 terms. One is called active transfer, and that means that you can tell them what to do, you can tell them, hey, we're gonna stand on 3, and they need minimal help. You're there with them, but they don't require much at all. The second one is called assisted transfer or assistive transfer. Now again, you can give them instructions and they can help some, but they need something. Maybe when you're having them stand, they'll put their hands on your shoulder. Maybe again, you'll use that transfer belt or gate belt to give them a sense of security. And then the last one is passive transfer, and they cannot help. This is again now where I'm using 2 people, I'm using a device, I'm using something to make that move. Now these terms, active, assistive, and passive, are also used in other areas of this class. One is going to be when we start learning range of motion exercises, which is where we'll prevent contractures. There will be range of motion exercises that are active, meaning I can tell the resident, okay, reach up to the sky and let's stretch your arm. Or assistive, let's lift your arm, and they start, but they need just a little bit of help getting up. Or passive, they don't do it at all. And now I'm actually doing the full mechanism of movement for them. So these terms are used in multiple settings for healthcare. Again, the entire goal through this process is to ensure that you are safe. That's the most important. Most people want to say, well, I need to make sure the resident is safe. Yes, you are actually more important than the resident, because if you injure yourself, the resident is likely to get injured as well, and then you're out of the equation. In the EMS realm that my husband's in, the first thing when they ever go to a scene, whenever you're asked what's the first thing you do when you arrive at that car accident or you arrive at that resident's home, and of course everybody wants to go, well, I'm going to say, hey, are you okay? What's going on? The answer is always, is the scene safe? Always, always, always. Because you have to protect yourself through any of the things that you're going to be doing with movement or transfers. All right, any questions about the movements, transfers, bed sores? Again, I'm giving you some diagrams in your book. There's a pressure sore zone diagram on page 32 for you. There's some list of things to actually look for with the skin breakdown. There's a diagram of the different positions that I've listed on the board. And so those are the things that you want to be familiar with. Yes?
There was, I once strained myself with a woman that, she was like 80, 90 pounds, and I made the mistake of not positioning myself correctly. I was slightly off, and I felt it.
Yeah.
And it was because I thought, oh, she's only 80, 90 pounds. No, 80, 90 pounds can strain you.
Yeah, it is. And body mechanics is important with that process. One of the other things that is important, and this is not, I don't even believe mentioned in this chapter, but trying to also get the height of what you're working, again, to be safe for you. So if I'm going to be doing something in the bed with turning or pulling them up and down, it's going to be better if the height of the bed protects my back as I'm making that movement, not leaning over to make those moves or transfers, even getting them to a sitting position. So you can raise the height of the bed to your working level, as long as you remember that when you get ready to leave the room, you got to make sure that you put it back down in the lowest or safest position for the resident. Now, what we're going to do is we're going to look at how to apply this to our first skill of your class, which is transferring to a wheelchair using a gait belt. So we're gonna learn the body mechanics of how we should stand. We're gonna learn the mechanics of putting on a transfer belt, how snug it should be, how our hands should be placed, and assisting that patient to transfer, because you're gonna do a lot of that. And a lot of them can bear minimal weight, as long as the wheelchair is positioned very close and we're basically doing a stand and pivot. Probably most of you have some sort of social media, but I know recently somebody from one of the European countries has put out a device. It's like a round disc, and have you seen that? And you set them down, and when you stand to pivot, they're standing on this, it's almost like a lazy Susan from your kitchen cabinet, and it just spins them and sits down. Wow, boy, I wish I'd have thought about that. That's gonna make a lot of money. But anything, again, that can help you through that process to ensure your safety and the client's safety is the most important. So if you guys will go ahead and get your skill book out, that's the small book that has your 22 skills in it. Let's look at our first